I'm very glad to present Dr. Maggie DiNome. We are very happy that she can join us from the US. So she just woke up probably. And she's a professor of surgery at Duke University, School of Medicine, and medical director of the breast cancer services at Wake County. She has an amazing CV record, and she undergraduated in Yale University. Her medical degree is from Duke, and then she completed her surgical training residence at Harvard's Brigham and Women's Hospital. She's also very interested in translational research focusing on epigenetics on breast cancer, with many collaborations with Diego Marcese. And her talk today is entitled Evolving Management of the Axilla in Breast Cancer Patients with Clinically Positive Notes. So whenever you want, Maggie.
Okay. Hold on for some reason. I'm having problems sharing my screen for some reason. Hang on one second. Okay, can you see my screen and hear me?
Sure, yeah, go ahead.
Okay, great, perfect. Sorry about that. So thank you so much for the invitation to come and spend the afternoon with you. And I do wish I could have been there in person, and I was looking forward to seeing Mallorca, but hopefully another year. So I will be speaking to you today about the evolving management of the axilla in breast cancer patients with clinically positive nodes. And this is a rapidly evolving field. Over the last decade, we've had many practice-changing randomized trials that have guided our management of the axilla, and I'm hoping to present the data to you that we have that informs kind of how we approach the axilla. So as a breast surgeon, I obviously need to know that what I'm doing is actually having a meaningful effect. So I need to know, am I improving a patient's survival? Am I helping to increase their cure by what I'm doing? Or am I providing prognostic information, valuable information that can help a patient to know their overall outcome? Or am I giving information that's going to help guide treatment? And those are kind of the questions that we ask ourselves as surgeons when we do axillary surgery. So over the last 10 years, we've had several randomized control trials that have demonstrated that axillary lymph node dissection, which is the removal of up to 20 lymph nodes from the axilla, does not improve a patient's survival outcome, nor does it improve local regional recurrence rates when they have sentinel node positive disease. Prior to these studies, we were removing lymph nodes under the axilla for patients who had sentinel node positive disease, but these randomized trials demonstrated to us that additional surgery was not beneficial. These studies looked at patients with both micrometastatic disease as well as macrometastatic disease, and the outcomes were the same. Patients were randomized either to lymph node dissection or no additional axillary treatment, or to axillary radiation. I think one of the more important things as a surgeon that I recognize from these studies is that in a great number of patients, the range was 13% with the micrometastatic disease up to 38% in the ATOASAR studies, but a great percentage of patients, we were leaving undissected disease left behind in the axilla. And these patients still did not have increased rates of local regional recurrence, and they did not have worsened survival. So surgical clearance of the axilla in the setting of sentinel node positive disease is not necessary. So we are not improving survival by doing axillary lymph node dissections. Well, then, are we providing valuable prognostic information? Certainly, at least historically, patients who had positive lymph nodes, we know that their survival was worse than patients who had negative lymph nodes. So knowing whether or not patients had positive lymph node disease was an important prognostic indicator, even such that our entire staging system is based on whether or not a patient has positive lymph nodes. But what we've learned as we have learned more about the biology of breast cancer, the different types of breast cancer, is that tumor biology influences prognosis and stage as much as, if not more, than lymph node status. So if you look at our revised staging system that came out in 2018, we went from 19 categories of staging based on anatomical stage, including tumor size, nodal status, and metastases, to over 120 categories now, when we incorporate all of the prognostic features, including grade, estrogen receptor expression, progesterone receptor expression, and HER2 status. So it's become very complicated when you are evaluating the prognostic variables that go into cancer stage. But if you look closely here, I think the things that are fascinating, patients who have N1 disease can now be downstage to stage 1 if they have low to intermediate grade tumors and estrogen and progesterone positive tumors. And even still, patients with N2 disease, so 4 to 9 positive lymph nodes, they will get downstage from stage 3 down to a stage 2 if they have estrogen positive, progesterone positive cancers, regardless of grade. So the biology of a patient's tumor is significantly influencing overall prognosis, in some cases more than the nodal stage. So we're not using it as much for prognostic information as we understand the biology of the different breast cancers. Well, how about treatment? Well, we know that from these randomized trials that whether or not you have a positive sentinel node or a negative sentinel node, we're no longer recommending axillary lymph node dissection. So the status of the sentinel node is not really informing surgical decision-making anymore. We know from the recent responder data that tumor biology is also influencing chemotherapy recommendation more than nodal stage. So the responder trial showed us that patients with 1 to 3 positive nodes with an estrogen positive tumor, if they have a low to intermediate oncotype score and they are postmenopausal, they will not be recommended for chemotherapy despite the fact that they have 1 to 3 positive nodes. So knowing the status of the sentinel nodes is not really dictating chemotherapy recommendation anymore. So really, based on all of this information, the NCCN do state in their guidelines that the performance of axillary staging for patients with clinically negative nodes may be considered optional. And we are even omitting surgical staging of the axilla in patients over age 70 with favorable tumors. And I predict that in the course of the next 5 years or so, we are going to be finding more subgroups of patients in whom we are going to be omitting surgical staging of the axilla if they have clinically negative nodes, because it is not improving survival, it's not informing prognosis, and it's certainly not altering treatment recommendations. Well, what about the patients with clinically positive nodes? So we need to ask ourselves the same questions. Are we improving survival by doing axillary lymph node dissection? Are we providing important prognostic information, or are we helping to inform treatment recommendations? So unlike patients with sentinel node positive disease, we don't have any modern randomized control trials. All of our randomized control data is historic data back from the 1960s and 1970s. But we do have randomized data looking specifically at patients who present with clinically positive nodes. And certainly you might imagine at that time, we did not have routine screening. We didn't have diagnostic ultrasound. So these patients were truly patients who presented with clinically palpable nodes. We weren't staging them with sentinel node biopsy at that time. So these patients had large burden of nodal disease, and they were randomized to either the Halsted radical mastectomy, which included a complete lymph node dissection, or no surgery in the axilla, but treatment with radiation instead. And the majority of these randomized trials have shown that at every time point measured, that there was no difference in overall survival in patients who were treated with radiation versus axillary lymph node dissection. One study did show a difference in overall survival. That was the Atkins study, but one of the criticisms of that study is that they only used 2,700 rads of radiation, which in modern day is considered suboptimal for local regional control. So I think one of the other important things to recognize in this specific, in all of these studies, is that we had no effective systemic therapy at this time, and yet there was still no benefit in axillary clearance with surgery based on these data. So what did change, and what allows us to ask ourselves, can we de-escalate surgery in the axilla for patients with clinically positive disease, is really the development of the effective systemic therapy. So adjuvant chemotherapy started in the 1970s, 1980s for cancer, and we've started to see a decline in mortality in the 1990s. And this has been attributed both to widespread screening mammography, but also to the development of effective systemic therapies. And we continue to see a significant decline in mortality early in the 21st century based on the effective targeted therapies that have developed for breast cancer. So all of this progress by our medical oncologists have allowed us to ask the question, can we de-escalate axillary surgery for patients with clinically positive nodes? So we started treating patients with neoadjuvant chemotherapy for clinical downstaging, but also recognizing that this was a very valuable way of an in vivo assessment of clinical response to tumor. And what we noticed is that quite a number of patients would receive an axillary PCR based on subtype of tumor, and that if a patient did achieve an axillary PCR, their survival outcome was significantly improved over patients who had residual nodal disease. What's equally important to recognize is that this same difference was not noted in patients who had residual breast disease. So whether or not you achieved a breast PCR or you had residual disease in the breast did not appear to impact survival as much as the stage in the nodes. So axillary PCR did appear to be a very strong prognostic indicator. So it does seem very valuable to assess the nodal status in patients after they have chemotherapy. But the question is, can we do that in a less morbid way? Do we need to do a complete lymph node dissection to be able to evaluate the nodal status after chemotherapy? So there were several trials that were conducted specifically to ask this question. Can we perform sentinel lymph node biopsy after chemotherapy with sufficient accuracy that it can replace axillary lymph node dissection for surgical staging? Now, the false negative rate that they pre-specified was less than 10%, because that was the false negative rate that was demonstrated with sentinel lymph node biopsy in patients with clinically negative axilla. So these specific studies all included patients who had sentinel lymph node biopsy followed immediately by axillary lymph node dissection. And while dual tracer with radio-labeled colloid as well as a colored dye was encouraged, it was not mandatory for these studies. And so the primary endpoint was to evaluate whether the false negative rate was sufficient enough that we could replace axillary lymph node dissection. And what these studies showed was that the false negative rate didn't meet the pre-specified endpoint of less than 10%, and they ranged somewhere between 12 to 14%. But if you looked closer, you could identify certain factors that did decrease false negative rates. And one of those was using dual tracer mapping. So if you did use both radio-labeled colloid as well as blue dye, you can get the false negative rate to single digits. And as well, if you are able to remove and assess 3 or more sentinel nodes, the false negative rate also drops below 10%. And that makes sense. I mean, the more tissue that you're able to sample, the lower you're going to make your false negative rate. But then how many patients actually were we able to find 3 or more sentinel nodes? And the answer to that was actually not very many. So in only a third to up to 60% of patients could we find 3 or more sentinel nodes. So the false negative rate was actually over 20% or close to 20% in patients if you only found 2 sentinel nodes. So based on this, an unplanned analysis was performed in the ACOSOC Z1071 study. So about a third of patients actually had a surgical clip placed into the lymph node at the time of the lymph node biopsy. And if you actually looked and to see if any of the sentinel lymph nodes contained this clip, and you were able to evaluate this clipped node, the false negative rate did drop to 6.8%. So it appeared to be beneficial to identify the clipped node. So based on this information, the NCCN did support sentinel lymph node biopsy after neoadjuvant chemotherapy. If you used dual tracer mapping, you were able to retrieve at least 3 sentinel nodes, and if you considered marking the biopsy-proven lymph node with a biopsy clip to confirm retrieval. The problem is in the ACOSOC Z1071 study, only in 24% of patients, the clip node was not a sentinel node. So the clip wasn't found as a sentinel node. It was actually in the additional nodes within the axillary specimen. So based on this, the group from MD Anderson developed the targeted axillary dissection procedure. This specific procedure specifically localizes and removes the clipped node in addition to the sentinel nodes. The protocol in the localization technique that they used was placement of a radioactive I-125 seed, and this had to be placed within 5 days of surgery based on our regulatory requirements in the US. They also found that the clip node was not a sentinel node in up to 23% of cases, and this highlights the importance of specifically looking for the clipped node in addition to doing the sentinel lymph node mapping. But if you did do a targeted lymph node dissection, the false negative rate was reduced to as low as 2%. But there are always challenges with new techniques and technology, and that's kind of what we face as surgeons. So of the patients who attempted to have clip localization, in 20% of them, the clip couldn't be localized. And in 8% of patients, we had to use CT in order to identify that clip and to localize the clip. So there were challenges associated with localizing that clipped node. Multiple subsequent studies were performed to try to identify ways of improving localization, and the success ranged from 30% to 97%. So there is quite a lot of variability in terms of being able to localize that clipped node. And it makes sense when you look at a lymph node before chemotherapy. Under ultrasound, it's very easy to identify. It's very abnormal, but after treatment with chemotherapy, that lymph node essentially normalizes and goes away. And the only thing you're left with is trying to find this little clip and localizing that clip. But what we've also found is that clip can get dislodged in a certain number of patients, so that after chemotherapy, you're actually localizing a clip that's no longer in a lymph node, and it's actually in the axillary fat. So these are challenges that we found with trying to localize the clipped node. So what we did at my former institution is we repurposed the Savvy Scout, and I think you're probably all familiar with the Savvy Scout, but it is an alternative to the wire that we use as breast surgeons to localize non-palpable lesions in the breast, to help us to know where it is in the breast to remove it. The Savvy Scout is really quite small, and it's a part of a radar localization system that we have in the operating room. So we have a probe that sends off a radar signal that locks in on these antennae, and it creates a circuit that provides a feedback so that I can actually find this device in the breast with the probe. So shortly in around 2017, this specific device was FDA approved for long-term placement. Prior to that, it was only approved for placement for 30 days. So once the FDA approved that this device can be placed in soft tissue long-term, we started placing this device into the lymph node before chemotherapy, when it was much easier to see the lymph node. And this device stayed in the patients throughout the course of chemotherapy until they came to surgery. This was a simple variation in clinical practice. It was placing this device into the lymph node before chemotherapy rather than placing it after chemotherapy. On average, the Savvy Scout stayed in patients for about 141 days, and all of these, the Savvy Scout was able to be successfully placed in all patients. So the results of this trial, it was a small feasibility trial, so we only targeted 25 patients for accrual. We were able to localize the lymph node and place the Savvy in all 25 patients very easily under ultrasound guidance. 23 out of the 25 patients responded clinically, so they were eligible for our targeted axillary dissection. On average, we had 4 sentinel lymph nodes that were removed, compared to the average of 2 that were removed in the MD Anderson and Mayo Clinic studies. Our Savvy was successfully retrieved in all 100% of patients. Interestingly, the clip was not in a lymph node in 13% of patients. In one patient, the clip was found in the surrounding axillary fat, and in another patient, the clip was never identified in any of the lymph node specimens. The Savvy was a sentinel node in 96% of patients in our study, which is significantly higher than the other studies. And this may be due to the fact that we did require dual tracer. So we were able to identify 4 lymph nodes on average in every patient, and that enabled us to identify the metastatic node in 96% of patients as a sentinel node. We did see a nodal PCR rate of 48%, and of the patients who had residual disease in the nodes, the Savvy node did detect disease in all of those patients. So since the completion of this trial, we have been routinely placing a Savvy node into the metastatic lymph node in patients undergoing neoadjuvant chemotherapy. And it has really enabled us to successfully localize this node for targeted dissection. So then we ask ourselves, well, what do we do now with the data of the sentinel node status? And the good news is we've got 2 randomized trials that are currently open and accruing patients to answer these questions. So the NSABP B51 RTOG 1304 study is for patients who do achieve a nodal PCR after neoadjuvant chemotherapy. So these patients are randomized to either regional nodal irradiation or no radiation at all. Currently, we treat these patients based on their pre-chemotherapy status, so almost all of them are receiving radiation to the nodes after chemotherapy, but it's obviously a very logical question to ask, can we omit radiation in this group who does achieve a nodal PCR? So this study will answer that question for us, and it's expected to close in 2028. Of equal importance is the Alliance A11202 study, and this is actually the counterpart study looking at how do we manage the patients with residual nodal disease after chemotherapy. So this specific study is randomizing patients with residual nodal disease to either completion axillary lymph node dissection or axillary radiation, and both groups are receiving regional nodal irradiation. And this study is expected to complete in 2024, so only a few short years away, and hopefully we'll have information regarding the patients with residual nodal disease. So it is clear that surgical staging of the axilla in patients with clinically positive nodes after neoadjuvant chemotherapy does give us prognostic information in terms of achieving a nodal PCR or not. But how about those patients who are not good candidates for downstaging. So clearly we see that the ability to achieve a nodal PCR is based on tumor subtype, and patients with triple negative and HER2 positive disease have much higher rates of about 45 to 65% of achieving a nodal PCR. Unlike patients who have hormone positive HER2 negative breast cancers, their rates of nodal PCR is actually quite lower. And Diego had asked Dr. Cortez previously if the immunotherapy impacted rates of nodal PCR versus breast PCR. And interestingly, what we find in the estrogen positive HER2 negative cohort is that we do achieve higher rates of nodal PCR than we do for breast PCR. And I don't exactly know the reasoning behind that, but it seems to be something that we've seen across multiple studies. The rates of achieving PCR in the nodes is pretty low. It's roughly around 12 to 18%, not really exceeding 20% in most studies. And these rates are similar with neoadjuvant chemotherapy as well as neoadjuvant endocrine therapy. A recent study a few years ago from Memorial did demonstrate that patients with progesterone receptor negative tumors and high-grade tumors were able to achieve a nodal PCR rate of 35% to neoadjuvant chemotherapy, but generally the rates don't quite meet the same rates as the subgroup of patients with the higher biology of tumor. Interestingly, though, patients with residual disease, the overall survival is still significantly higher in patients with ER-positive tumors than patients with ER-negative tumors. So residual disease in estrogen receptor-positive tumor doesn't carry the same prognostic impact as it does in patients with the higher biology of breast cancer. And also we know that for many patients with ER-positive breast cancer and nodal disease, based on the responder data, that chemotherapy, certainly neoadjuvant chemotherapy, may not give us any significant benefit. So for those patients then who are not being recommended for chemotherapy but do have clinically positive nodes are being recommended for surgery first, several studies have asked, well, what about patients with ultrasound detected nodal disease who don't have clinically palpable nodes, but are nonetheless clinically positive because they are identified to have nodal metastases at the time of diagnosis? And this question was asked specifically because the ACOSOG Z11 study did not require that patients had to have a negative ultrasound in order to be included in the study. So there could be a number of patients that were included in the study who did have ultrasound detectable disease, but they were clinically negative by criteria for study inclusion. So after the publication of Z11, several studies looked at, well, what about patients with ultrasound detected metastases? Could they be managed according to Z11 criteria? And I think the important things to point out is that a large majority of patients, anywhere from 40 to 65% of patients who had ultrasound detected nodal disease had very low volume of pathologic nodal disease at the time of axillary lymph node dissection, so 1 to 3 positive nodes only. They did find that patients who had ultrasound detected disease compared to those who had sentinel lymph node detected disease did have higher risk markers like greater rates of LVI, higher grade tumors. But these studies also included about a quarter of patients who had estrogen negative disease. And in the modern day, the patients with estrogen negative disease and ultrasound detected metastases would likely be treated with neoadjuvant chemotherapy. So the patients who will go on to surgery first are likely those who have estrogen positive disease. But even still, even with the variation in the prognostic factors, the only things that consistently predicted for higher nodal stage in the ultrasound detected group were tumor size and lobular histology. So based on this data, the NCCN recently, as of 2 months ago, really updated their guidelines so that now if patients have non-palpable disease, but ultrasound detected and biopsy proven nodal metastases, they are still eligible for sentinel node mapping and sentinel node biopsy. So they no longer have to be treated with axillary lymph node dissection based on these subsequent data. However, the NCCN still relegates the patients with palpable nodes to axillary lymph node dissection if they're not being downstage with chemotherapy. And they do include patients with palpable nodes in the same category as patients with greater than or equal to 3 suspicious nodes on imaging. And I think, a lot of these recommendations are based on older historic data because we don't have a lot of information on patients with palpable nodes. And quite honestly, it's because patients with clinically positive and certainly patients with palpable nodes have been excluded from all of the practice-changing clinical trials that have been conducted over the last decade. So we really have very little data about this patient group. And so for these patients, actually lymph node dissection is still recommended. And it's based on the following assumptions, I believe, that palpable adenopathy is associated with higher risk features, and therefore surgical clearance of the axilla is recommended. And this doesn't really make sense to me because in what scenario have we demonstrated that more surgery makes up for bad biology? And I don't think that's the case. So while maybe these patients will be recommended for more adjuvant therapies, which I think is appropriate, I don't necessarily think that higher risk features indicates the need for axillary lymph node dissection. Also, palpable adenopathy has historically been associated with higher nodal stage. And in a lot of instances, this is because the information that we have was based on cohorts of patients who presented with palpable adenopathy decades ago, and certainly the patients that present with palpable adenopathy in this day and age are going to be completely different. We're certainly screening patients more widely, identifying patients at earlier stages. We know more about the biology of tumors, so patients with palpable adenopathy with worsened biology are treated with chemotherapy first. So also, the assumption that patients with palpable adenopathy still require surgical clearance. That's kind of where we stand with this subgroup. And I think that, I hope anyway, that we'll start making some inroads in progress by addressing this group as well. So one thing, we've really whittled this group down to a very small cohort of patients now who arguably have probably the better biology of tumor. So the patients who have palpable nodes that are going straight to surgery are almost invariably all strongly ER positive, because even those with low estrogen receptor expression, so although they're considered positive because they have a greater than 1% of staining, those with low positivity of 1 to 10% are being considered for neoadjuvant chemotherapy, because we do recognize that they respond more similarly to patients as if they were estrogen negative. So really the patients that are going straight to surgery are those with much stronger ER expression. Also, what we have to recognize is that patients, these patients, their cancer is truly treatment naive. The axillary disease is not persistent disease like it is in the post-neoadjuvant chemotherapy setting. And interestingly, we are asking if we should be de-escalating axillary surgery through the Alliance 11202 study in patients who have chemotherapy-resistant nodal disease, yet we're not asking that same question for patients whose nodal disease is completely treatment naive. And finally, for this group of patients that's strongly estrogen receptor positive, we have multiple lines of effective targeted therapies beyond all of our endocrine therapy, the tamoxifen, the aromatase inhibitors, ovarian suppression, et cetera. We do have some recent data that suggests that the CDK4/6 inhibitor abemaciclib may reduce recurrence risk in the adjuvant setting in patients with high risk ER-positive breast cancer. And there are some studies looking at PIK3CA kinase inhibitors, and early studies demonstrate progression-free survival improvement in patients with PIK3CA mutated estrogen-positive breast cancers. So studies are looking at moving other targeted therapies into the adjuvant setting for patients with ER-positive tumors, and certainly we have many more options than patients with ER-negative tumors. So our group, as well as the group from Memorial, recently looked at the more modern day cohort of patients with clinically positive nodes who proceed straight to surgery. And as you can see, most of these patients are estrogen receptor positive, which makes sense. And the great majority of these patients had palpable adenopathy. Yet what we find is that 40 to almost 60% of patients still have low volume of nodal disease at the time of axillary dissection. And similar to the ultrasound detected nodal disease group, lobular histology and T3 tumor size were the only factors that predicted for a higher nodal stage. So even though patients did have higher risk features, as we mentioned before, in terms of higher grade LVI, those didn't predict for higher nodal stage. The only things that did were histology and tumor size. And palpable adenopathy as a variable was not predictive of higher nodal stage. So here we are at a point where we have got several nomograms that are looking at predicting non-sentinel node disease in patients with sentinel node positive tumors, and they evaluate clinical pathologic features, and their accuracy is not very high, so they've not been used clinically in widespread fashion. We don't have any similar nomograms looking at patients with clinically palpable nodes who proceed straight to surgery. And so, as Dr. Cortez had mentioned, that he feels that signatures may end up being the better predictors and classifiers beyond just biomarkers themselves. So Dr. Mercez and his group and our group, we have been capitalizing on Dr. Mercez's expertise in cancer epigenetics and my clinical interest in downstaging axillary surgery for patients with clinically palpable nodes. We are looking at identifying some molecular signatures, epigenetic signatures that can maybe be used to help predict more higher nodal stage in patients with palpable nodes. So we recently looked at data from the Cancer Genome Atlas Project, over 1,000 breast cancer patients with axillary surgery data. We excluded estrogen negative and HER2 positive patients who would otherwise be treated with neoadjuvant chemotherapy and just focused on the groups with estrogen positive, HER2 negative disease. We also excluded patients who were initially staged with sentinel lymph node biopsy and then went on to axillary lymph node dissection, and only included the patients who went straight to axillary lymph node dissection for clinically positive nodes. And we looked at the DNA methylation data and the epigenetic data to see whether or not we can identify predictors that were associated with P1 versus greater than P1 disease. And I think this is really exciting data. We're able to identify 3 epigenetic signatures based on 14, 13, or 10 different genomic regions that had very high predictive value for greater than PN1 disease, so patients who had 4 or more positive nodes. This was validated in another patient cohort, and the AUC of these epigenetic signatures reached 0.92, 0.91, and 0.92. And these epigenetic signatures were significantly more predictive than the clinical pathologic variables that we identified in our study. So based on this information, I think this is a great basis for looking at a clinical trial that's evaluating targeted axillary dissection in lieu of axillary lymph node dissection for patients who have ER-positive disease and clinically palpable nodes. If we can stratify patients with the epigenetic signature that suggests that they are in the PN1 group, those patients I think would be better served with a targeted dissection versus an axillary lymph node dissection. So I think that's very exciting, and I thank Dr. Mercez and his group for the collaboration here. So just to summarize, I went through a lot of data that hopefully presents where we're at in terms of our management of the axilla for patients with clinically positive lymph nodes. So patients who have non-palpable disease, we know that sentinel lymph node only disease does not, those patients can be managed with sentinel lymph node biopsy alone, and that's based on those 5 randomized studies that I mentioned to you before. Now we also have data and NCCN recommendations that patients who have ultrasound detected nodal disease that is clinically non-palpable, they can also be treated with sentinel lymph node biopsy as the first surgical procedure for staging the axilla. For patients with palpable disease, we can attempt to clinically downstage them with neoadjuvant chemotherapy, and then those patients will be eligible for a targeted dissection and sentinel lymph node biopsy rather than axillary lymph node dissection for surgical staging. However, we're still at the point that patients who are not able to be clinically downstaged, and those are primarily going to be the patients with estrogen-positive tumors, they are still recommended for axillary lymph node dissection. But I am hopeful as we get more information on this patient group and we consider including them and not excluding them from clinical trials assessing de-escalation of axillary surgery, that hopefully we'll be able to treat these patients with a targeted dissection for surgical staging of the axilla rather than a complete lymph node dissection, understanding that we could reduce the morbidity that patients get from our surgical procedure. So that is all. Thanks for listening. I hope it wasn't terribly boring coming from a surgical point of view, but I'll take any questions if you have any.
Thank you very much for the talk, Maggie. Has anybody have a question for the speaker? In the audience. You, Dio?
Probably, but if you want to go. Okay. Dr. DiNome, thank you so much for your time, and especially at this time in North Carolina of the day. I hope you have a nice day after this starting. So your study at Annals of Surgical Oncology shows a clear association between the lobular histology and the involvement of the axillary disease. Have you seen, or is there any study showing this is the same for, this is true for every single different immunohistochemical, breast cancer subtype? I mean, ER positive, HER2 positive, or TNBCs, or is it just for ER positive?
You mean the lobular histology?
The association with the lymph node involvement.
Yeah, so the lobular histology as a variable is an independent predictor in multiple studies in terms of patients having greater than PN1 disease. But interestingly, it seems to be that lobular histology is so much more associated with N3 disease that that's where really the burden of the difference lies. So it's much clearer that patients who have lobular histology is significant in differentiating between P1, P2, and N1, N2, and N3 because there's so much a higher prevalence of lobular histology in N3 disease. You don't have that many patients with ductal histology having that much of a volume. In some studies, the ability to identify that significance between PN1 and greater than PN1 falls out because really the weight of the lobular is when you're trying to distinguish between the N3 and the N1, if that makes sense. The majority of all lobular cancers are estrogen positive. I'm not sure if that was what your question was. So because the majority of all lobular cancers are estrogen positive, we see that distinction primarily in the estrogen positive subgroup.
Thank you.
Okay, so any other question? No? Okay, so
Yeah,
you have another one?
I have
okay.
one more question.
Yeah.
So considering the importance of this histology on the tumor evolution, especially to the lymph node, and this is still kind of underrepresented on the AGCC staging of the disease, just consider a risk factor to be lobular. Do you think it should be considered in order for you to know in advance how to better stratify the patient clinically based on the staging? Adding the lobular disease as a kind of completely different disease for this classification.
You mean for the epigenetic classification?
No. For the
Staging.
AJCC, the staging of
Oh.
the disease, the clinical.
Yeah, I
stage.
don't know if I really understand your question, but they do include, so most lobular cancers, classic invasive lobular cancers, are strongly ERPR positive, HER2 negative with reasonably low grade. So rather than including the histology, they do kind of incorporate just grade and ERPR. If that's what your question is asking, Diego, I'm not, can you ask it again?
Indirectly, yes, it's included based on the immunohistochemistry markers, the lobular disease, the histology, but specifically as lobular is just considered a risk factor, as far as I understand on the HJCC guidelines. My question was if you should reconsider adding more stage to this patient, and then you feel more comfortable having a more aggressive surgical intervention for those patients.
Well, I think so. Yeah. So I think at the moment, I think that the patients that it would be so. There was a study out of Memorial, Dr. Morrow performed subsequent to the Z11. Does lobular histology predict the need for axillary lymph node dissection in patients who meet Z11 criteria? Because the assumption is that the way lobular histology spreads, it's more of a discontinuous kind of mode of spread because it's E-cadherin negative. Do these cells tend to separate and go into the lymphatics easier and to spread more? Her study actually showed that lobular histology in and of itself was not a indicator for need for axillary lymph node dissection if they otherwise meet Z11 criteria. So I don't know if we can necessarily say that all patients with lobular histology will not be able to forego axillary lymph node dissection. But I think the first step is because that variable is significantly associated with higher nodal stage. I'm sure there is a subgroup of patients within that group that have minimal nodal disease, and there certainly is. But I think as a first step in terms of trying to find that cohort of patient who can safely forego axillary lymph node dissection, we should look at the ductal group first because they have much higher rates of minimal lower kind of pathologic stage. So I don't know if I necessarily answered your question, Diego.
Yes,
I'm sorry,
yes,
but I do, yeah.
So thank you very much, Maggie. I think we can conclude this talk and move to the next one. Thank you very much.
Thank you.